Good afternoon, respected seniors and friends. This is Dr. Manish Kumar, Senior Consultant Neurosurgeon at Venkateswar Hospital, Dwarka, New Delhi. First of all, at the outset, I would like to thank our head of the department, Dr. Professor P.K. Sachdeva sir, and my senior Dr. Dhruv Chaturvedi sir for giving me the opportunity. Today we will discuss about one interesting case of cellular lesion. As we know, most of the cellular region lesions, the first diagnosis is pituitary macroadenoma, but it is not correct all the time. So today we will discuss one of such rare conditions, rare diagnosis, rare lesion. So we had a 36-year-old female who had come with complaints of headache and difficulty in vision because she was having double vision on looking towards right. On examination, she was having left lateral rectus palsy. Otherwise, fundus was normal and visual field defect had shown one small superior outer quadrant area of suspected loss of vision, field defect. Other than that, there was no abnormality. Blood investigations, including the hormone assays, were within normal limits. Radiologically, in T1 weighted image, there was a cellular supracellular ISO2 hypointense lesion. In T2 weighted image also, it was ISO2 hyperintense lesion. There was one small area of T1 hypointensity and T2 hyperintensity. Contrast pictures were remarkably important as there was brilliant enhancement of not only the cellular lesion but also the surrounding dura, which is not normal for pituitary macroadenoma or pituitary adenoma as such, where there is heterogeneous enhancement and surrounding dura does not enhance. For biopsy and decompression purpose, endoscopic transnasal transsphenoidal excision of the lesion was done, and not very surprisingly, the pathology report came as granulomatous caseous lesion with Langerhans giant cells, which was diagnostic of tuberculous granulomatous lesion. So, looking back, Retrospectively, patient did not have any other lesion intracranially or extracranially, especially in the lungs or any other part of the body. So it was a primary pituitary tuberculosis, which is extremely rare. It usually presents with visual symptoms and headache, sometimes seizure or hormonal abnormalities, cranial palsies. But most of the cases are misdiagnosed because of the location, where most of the time we easily brand it as pituitary macroadenoma. And histopathological diagnosis is the only and most important and the last way to catch the diagnosis. So histopathological diagnosis is essential irrespective of clinical and radiological findings. Among all the intracranial tumors, intracranial lesions, intracranial tuberculosis account for 0.15 to 4%. In the absence of pulmonary tuberculosis or other organ involvement, the primary tuberculosis is a very uncommon disease. So far, till 2020, only 106 cases had been reported across the world. So it is not very prevalent, very common lesion. As told earlier, headache, visual symptoms, endocrine abnormalities are the common features. Galactorrhea, amenorrhea might be there in females. Polyuria and polydipsia may also be present. MRI is the first line diagnostic modality, whereas I told that ISO to hypo or hyperintense heterogeneous contrast enhancing lesion, which is very difficult to differentiate from pituitary macroadenoma. But possible thickening of dura, surrounding dura, contrast enhancement of surrounding dura should raise the suspicion. Differential diagnosis of cystic solid mass in sella like carcinoma, adenoma, neurocystic sarcosis, pyogenic abscess, Rathke's cleft cyst, or craniopharyngioma has to be considered. On MRI, pituitary tuberculomas can be specifically associated with multiple coalescing lesions, and the normal pituitary gland is seen separately as a rim. Here in this case, in this MRI, it is seen on the posterior margin of sella. Pituitary adenoma is the commonest misdiagnosis for pituitary tuberculosis. Transspinodal approach, transnasal, transspinodal, endoscopic excision and biopsy is the preferred route for surgery, where we can obtain tissue for diagnosis without spreading, without contaminating the, without spreading the disease to the intracranial compartment, which is very easily possible if we go through intracranial route. Histopathological examination reveals epithelial cell granulomas, Langerhans giant cells, and occasionally caseous necrosis. In our case, caseous necrosis was seen. Sometimes we can also diagnose with polymerization chain reaction and CSF examination. Coming to the treatment, anti-tubercular drugs are important. Combination of bactericidal such as INH, rifampicin, pyrazinamide and streptomycin, which penetrate the blood-brain barrier effectively. They are prescribed. The regime may continue somewhere from 9 to 24 months, and reduction in size of the lesion can be appreciated after 8 weeks, and it usually resolves at the completion of the treatment regime.